Yap. Thanks, Nikita. Mei-Ling Yap is a clinical researcher whose focus is on achieving equity in cancer control locally and globally. She's a senior staff specialist, a radiation oncologist based in Southwestern Sydney Local Health District, as well as a senior research fellow at the George Institute for Global Health. She's a conjoint senior lecturer at UNSW and Western Sydney University, and an adjunct senior lecturer at Sydney University. She's working to support cancer services, capacity building in low and middle income countries in the Asia Pacific as co-chair of the Asia Pacific Special Interest Group of the Royal Australian and New Zealand College of Radiologists. So please give a warm welcome to Mei-Ling, and I'll hand the screen over to you. Thanks, Mei-Ling.
Thanks, Serena, for the introduction. Let me just share my screen. Okay. Is that good?
We can see it. Thank you.
Great. Okay, yeah, so thank you to Richard and Serena for inviting me to speak today. I've recently presented at a prostate cancer meeting, which Richard attended, and he reached out and said that there were potentially some synergies with some of the work that your team is doing. So I'm just going to present some work which was done as part of my PhD thesis, and it was done together with colleagues from the Daffodil Centre. And I can see that David Goldsberry is on the call as well, and he was central to this work. So prostate cancer is the most common cancer diagnosed in men in Australia. You can see from this graph that it's far and away the most common cancer diagnosed. When we look at deaths, there were 3,500 estimated for this year, as compared to almost 25,000 diagnoses. So the takeaway point is that most men will survive, they will be cured of their cancer. And there are many thousands of men walking around the community who have either been cured or still living with prostate cancer, meaning that the treatments that these men choose have potential longer-term implications for the rest of their life with regards to side effects. So the choice of treatment that these men have is very important. In terms of the main treatments for curative intent, that is men who have prostate cancer that hasn't spread further from the prostate area to other parts of the body, the main treatments include firstly surgery, and the surgery that's done is a radical prostatectomy where the entire prostate is removed. And in Australia, this is mostly done using a robotic technique, which is shown in this picture here, where the surgeon uses this robotic equipment to do the procedure. Most of the surgery done for prostate cancer is done in the private sector, and men typically have out-of-pocket costs associated with this, even if they use their private health insurance. And the main side effects from surgery include urinary incontinence, so they can have leakage, and also impotence, so the inability to gain erections. And with surgery, of course, it requires a general anesthetic, and patients might stay in hospital for around a week or so. And so the more elderly patients, this can also be a bit of a challenge and maybe a reason to look at other treatments. Radiation therapy is another potentially curative treatment for prostate cancer. And radiation therapy, or radiotherapy, it's the same thing. It uses ionizing radiation to damage cancer cell DNA, and this radiation is targeted to the prostate. So mostly radiation therapy is delivered as external beam radiotherapy. So delivered using a machine similar to one in this picture, a linear accelerator, where a patient will lie on what we call the radiation couch, although it doesn't really look that comfortable. So they're lying on this couch, and then the radiation machine will move around them, and a visible X-ray will go out to target the prostate cancer. So that's external beam radiotherapy is delivered as an outpatient. So people come to and from home usually for treatment. In terms of the side effects, tends to have lower urinary and impotent side effects compared to surgery, although a higher rate of bowel toxicity. And also, because it's done as an outpatient, people coming to and from home, they don't need a general anaesthetic to have it done. Traditionally, radiation treatment for prostate cancer was given over many weeks, up to about 9 weeks of treatment, Monday to Friday with the weekends off. In the last few years, there's emerged a newer treatment technique called stereotactic radiation therapy, which is a more focused type of treatment. It's still delivered through the same machine, the linear accelerator, but it has meant that treatment schedules can be reduced to over 1 to 2 weeks. So that has, been a great development for our patients, particularly those who are working where previously it'd been quite an inconvenience to have to come for treatment over such a long period of time. In New South Wales, most radiation therapy is delivered in the public sector. There is another type of radiation treatment, which we're not going to focus on in this talk, but just to let you know, brachytherapy is radiation therapy delivered internally into the prostate through radiation sources. And when brachytherapy is given, sometimes a general anaesthetic will be needed. But generally, this treatment now is less common in Australia. I guess with the developments that have been made with the external beam treatment, we see brachytherapy used less, and it's typically only used in a few specialist centres around Australia. And then there is a third management option for curative intent treatment, particularly for what we call low-risk prostate cancer, where it's diagnosed at an early stage, and there's criteria in which, strict criteria in which patients can qualify to have what we call active surveillance. And that's essentially monitoring the prostate cancer very closely, doing a number of different tests, including potentially repeat biopsies. And only if the prostate cancer then changes into a more aggressive looking cancer from these tests, will the patient then go and have a discussion about the treatment options. And active surveillance, again, I think it's really been over the last decade or so that that's becoming more popular. And it certainly is a good management option for some patients who qualify. So is one treatment better than the other? I think certainly in the setting of localized prostate cancer, the evidence is very clear that survival is the same, really, if you undertake surgery, radiation treatment, or active surveillance, as seen by this paper from the New England Journal that's now 6 years old. There really isn't any difference when you look at these three treatments with regards to survival. However, when we look at the patterns of care of prostate cancer in Australia, this paper looked at Victoria and South Australia. And what we can see here is that surgery was by far and away the most common treatment that was given. And with radiation treatment being really about half the number of men receiving radiation treatment. And over time, those numbers are dropping. So it doesn't reflect really the evidence that we see in terms of the survival being equivalent. A few years ago, this issue about the type of treatment for men with prostate cancer and the fact that surgery is being given more commonly led to a number of articles within the mainstream press, including quite lively debate on Late Line between a radiation oncologist and a urologist, with some really, I guess, heated discussions about could there be potentially other reasons why men with prostate cancer in Australia are receiving surgery more often than radiation therapy. And there was a lot of dialogue around the potential out-of-pocket costs that patients were receiving, particularly in the context of having surgery. So in light of this, we decided to undertake this study, which was to firstly describe the patterns of care for prostate cancer patients in the 45 and up study in New South Wales. And secondly, to ascertain which factors, and these include socio-economic factors that we'll discuss, are associated with treatment for prostate cancer. So we used data from the 45 and up study. So this is a large scale cohort study that was performed in New South Wales and is still ongoing, which recruited people who were people aged 45 years and over from the Medicare database. And so over 250,000 participants were recruited in New South Wales, aged 45 years and over. And importantly, these participants not only filled out a very extensive survey on their health, their lifestyle, and their socio-demographics, but they also then gave permission for their data to be linked to routinely collected data sets, which many of you will be familiar with, including the Medicare database, PBS, inpatient admissions through APDC, cancer registry, and also births, deaths, and marriages. So this gave us the opportunity to be able to study for the first time really on a granular level people's access to radiation therapy and what socio-demographic factors may be associated with this. In terms of the linked databases which were used, they're shown here. So we included any man who had developed prostate cancer after being recruited on study. And in order to identify those who'd received radiation therapy, we used both MBS and APDC records. Similarly for surgery, we used those data sets. For chemotherapy, we used those two, and in addition, the PBS data. And we also looked at androgen deprivation therapy, which we used the PBS data for. In terms of the socio-demographic and socio-economic factors that we looked at, firstly, we looked at measures of social isolation, their place of residence, their distance from the nearest radiotherapy centre, and their ethnicity. We also looked at health-related factors, including comorbidities and their physical functioning. And in terms of measures of socio-economic status, we looked at the annual household income, area-level socio-economic status, the individual's education level, their health insurance status, and whether or not they worked. And we use a competing risk regression to compare the receipt of radical prostatectomy versus no prostatectomy across the categories of socio-demographic factors. And we adjusted this for age and stage. And similarly, we used competing risk regression to compare the receipt of external beam radiotherapy versus no external beam radiotherapy. And we did multivariable models with purposeful selection of covariates. So in terms of the linkage, you can see that there were millions of records that were linked. We excluded men who had a Department of Veteran Affairs card because there was some concern that their records may be incomplete, certainly for PBS and possibly for MBS. We also excluded those who had been diagnosed with multiple cancers after being recruited on study. And we also excluded those who'd had any previous radiation therapy. And this, we ended up with just over 4,000 men who'd been diagnosed with prostate cancer after recruitment on study with a median follow-up of 5 years. So when we looked at the treatment received by the men in our cohort, similar to the Victorian and South Australian data, you can see that surgery was the most common treatment, and really about half the men who'd received surgery, half the number, then we had half the amount of men who received radiation therapy. 1 in 10 received just hormone treatment alone, and we had 1 in 5 who didn't have an active treatment such as surgery or radiation therapy, although we weren't able to ascertain if they were actually on that active surveillance regimen as opposed to having no treatment. When we look at localized prostate cancer and localized prostate cancer, low risk cancer, these are the patients where there's clear evidence that surgery and radiation therapy have equivalent outcomes. You can see that it's actually even more marked, with almost half the men receiving surgery and only 1 in 5 receiving radiation therapy. And again, we have smaller numbers receiving just hormone therapy, and 1 in 5 with no active treatment. Interestingly, our data is very different to what we see in the US. And in the US, the surgery and radiation therapy rates are actually very similar. In the US, they have very different models of reimbursement, and actually there are the typical setup for a center which is delivering radiation therapy is that there'll be urologists who own the center and then are referring within their center to radiation therapists, thereby really, I guess the reimbursements are different in the sense that the urologist will also have potentially benefits in referring to the radiation oncologist within their center, because often they will own that treatment center, which is obviously very different to what the model is within Australia. And similarly, in the UK, we see a different picture whereby radiation therapy uptake is much higher. And in the UK, of course, things are quite different, with majority of treatment being through NHS, publicly provided treatment, both for radiation therapy and surgery. So the patterns of care we see in Australia certainly contrast very differently, significantly to the US and the UK. We also were able to look at the number of patients who had radiation oncology consultations prior to surgery, because we had the MBS data. So we looked at, patients who went ahead with surgery for the potential cure of their treatment, whether or not they actually saw a radiation oncologist in consultation prior to that to potentially discuss another option. And you can see that those rates were very low, where 13% of men who had surgery had a formal consultation with a radiation oncologist prior to going ahead with the operation. Then we looked at the factors related to prostatectomy receipt. So you can see that age, certainly a factor where elderly patients are less likely to have surgery. Also, we found that those patients who have more localized or regional disease are more likely to receive an operation. Patients who had a higher body mass index, so who were obese, were less likely to have an operation. And those patients who had poorer physical functioning also less likely to have an operation. Interestingly, we found that patients who were single as opposed to partnered or married were less likely to have surgery. Patients who lived more than 100 kilometers from the nearest radiotherapy center were more likely to have surgery. Patients who were in more disadvantaged socio-economic status quintiles were less likely to receive surgery. And interestingly, the patients who had no private health insurance were less likely to receive an operation as well. When we move on to radiation therapy, again, we found that age was predictive, with patients who were in the 70 to 79 age group more likely to receive radiation therapy. Patients who had regional or distant disease are more likely to receive radiation therapy. Patients who had more comorbidities were less likely to receive it. Patients who lived further from a nearest radiotherapy center, again, less likely to receive radiation therapy. And I guess as a complement to what we saw with surgery, we found that patients who did not have private health insurance were more likely to receive radiation therapy. We also found that patients who were working were less likely to receive radiation therapy. So just to summarize, in terms of the factors predicting for the type of treatment, I think it was that the health factors that were predictive are quite, I think, self-explanatory and make sense. Those who have more comorbidities, high BMI, etc., are less likely to receive surgery and radiation therapy. The socio-demographic factors, some of them, I guess, were less intuitive to us. Partnered patients, we found, were more likely to receive surgery, which I guess questions the role of the partner in decision-making, in that those who were partnered were less likely to go ahead with it. Patients living more than 100 kilometers from the nearest radiation center were less likely to receive radiotherapy. and conversely were more likely to receive surgery, which highlights the poor access to radiotherapy for some patients. And patients who work full-time are less likely to access radiation therapy. As mentioned, the cohort from this study would have had treatment at the time when most treatment was given over 7 to 9 weeks. However, more recently, there are newer, shorter treatment schedules, which hopefully will mean that patients who work will be less put out by potentially accessing radiation therapy. We also found that surgery was more common for patients who could afford it. So men living in disadvantaged areas were less likely to have surgery. Men who had private health insurance were more likely to have surgery and less likely to have radiation therapy. Importantly, radiation therapy is not covered by private health insurance. Patients who access radiation therapy in the private sector, go to a private center and have their treatment. I think I've heard that your group is doing some research in this area, but typically Medicare will get billed, but then there'll be additional out-of-pocket costs for that patient, but they're not able to actually use their private health insurance for the radiation treatment. Why is the choice of treatment important if the survival is the same, whether it be surgery or radiation therapy? So it's important because we know that the treatment decisions for prostate cancer will lead to potentially long-term, lifelong toxicities. As mentioned, for surgery, these could be urinary and sexual side effects. For radiation therapy, these could be bowel side effects. And there has been work that has shown that men with prostate cancer often experience decision regret. Despite this, we found that patients were twice as likely to receive surgery compared to radiation therapy, and only 1 in 8 men saw a radiation oncologist prior to undergoing their surgery for prostate cancer. The choice of treatment is also important because there can be significant financial toxicity from prostate cancer treatment within Australia, with data showing that out-of-pocket costs can be, for men, with 75% spending up to $17,000 for their prostate cancer treatment, and that the out-of-pocket costs for men with prostate cancer were found to be higher for those with private health insurance. In our study within our cohort, 3/4 of men who had surgery received it within a private hospital. However, for radiation therapy in New South Wales, most is delivered in public hospitals, and there's no additional out-of-pocket costs given to the treatment centre. So this is an interesting qualitative study which was done, which interviewed men with prostate cancer who were actually able to see both a surgeon and a radiation oncologist within a combined uro-oncology clinic. And the study was interesting because it suggested that treatment choices were predominantly influenced by the clinician, and most commonly that's the urologist's recommendations, because all these men who went to this combined clinic had already been seen by a urologist prior to this for the diagnosis. Patients mistakenly believed that surgery provides a more definitive cure than radiotherapy. Patients concluded that they valued seeing both a urologist and radiation oncologist, and that patients need information about all treatments earlier in the treatment decision-making. Because there were some men who went to this combined uro-oncology clinic who had already decided they were going to undertake surgery based on their initial consultations with the urologist, who is the person who makes the diagnosis of prostate cancer. The limitations of our study were that the sample population is the 45 and up study cohort, which is not the whole of New South Wales. And it meant that there were fewer culturally linguistically diverse patients, and likely more health literate patients, because they had to fill out that quite extensive survey. And this study also purposely oversampled elderly and rural patients. In terms of the clinical data we had access to, there were a high proportion of patients with unknown stage, which we see in the New South Wales Cancer Registry due to the way that they actually stage patients. And we did not have what we call T&M categories, which again is a more granular way of staging patients. and we didn't have Gleason score, which is important in risk stratification for prostate cancer. We were also unable to differentiate whether patients who were having no active treatment were actually on active surveillance. And of course, there was a time lag in the availability of data based on the cancer registry and how recent their data is. So to conclude, despite the evidence, patients with prostate cancer had twice the utilisation of prostatectomy than radiotherapy, with a low percentage of surgical patients having a radiation oncology consult prior. And that raises the question of whether patients have full understanding of the options. We found that patients who were partnered were more likely to receive surgery, and that distance from the radiation therapy centre was predictive of treatment. And lastly, that the ability to pay appears to be influencing the type of treatment received. In terms of future solutions, I think we need a better understanding of the patient experience, and there's certainly a lot of work in this area. Patients in rural and remote regions, they need further initiatives to help their ability to access both surgery and radiation therapy. Uro-oncology specialist clinics are ideal, where a patient could see a urologist and a radiation oncologist at the same time. However, there are very few of these in Australia, whereas they're very common in the United Kingdom. We need more education of patients, partners, caregivers, and doctors on the options for prostate cancer, and decision aids could be helpful. And lastly, we need to review the policies that not only affect access to care, but that also affect the reimbursement schedules for the different treatment options for men with prostate cancer in Australia. So a positive thing that has come out in the last few years is that there's been a change, working around, because of this issue that we talk about in terms of referrals to radiation oncologists before surgery. There's actually been a change to the MBS wording for the codes for prostatectomy that say that there should be multidisciplinary management, including team review documented in writing and provided to the patient, and that men should be encouraged to see both a urologist and a radiation oncologist to discuss their options. If you want to have a look at this work in more detail, this was published in the MJA last year, and with a editorial that was associated with it, with both a surgeon and a radiation oncologist giving their opinion. So I'd just like to acknowledge all the collaborators on this work from the Daffodil Centre, as well as from CCOR Ingham Institute, and of course, all the participants in the 45 and up study. And it's just open to any questions. Thank you.
Thank you, Mei-Ling, for that really fascinating presentation. Did anyone have any questions? Oh, Jane, did you want to jump?
I'm jumping in. Mei-Ling, I wondered if you could look at the active surveillance by looking in the MBS data for repeated PSA tests or indeed a biopsy, whether that would give you a better indication. So that's the first question, because that follow-up is very interesting. The other thing we might discuss, though, is sort of radiotherapy and how you ensure equitable access, given we're a big country with a lot of remote and difficult rural areas, when you've got something that is so capital intensive. And I wondered if you'd like to expand on that.
Yep, so the first question, yes, that's a good point, that I think in terms of active surveillance, there are ways to potentially capture that using MBS. It was outside the scope of our study, but yes, I think biopsies and PSAs would certainly be a way to potentially capture that for future work. With regards to access to radiation therapy in regional and remote areas, it certainly is an ongoing issue. There have been some improvements in the last decade. So new centres that have popped up in the North Coast, Lismore, Port Macquarie, Coffs Harbour, in the South Coast, in Nowra. So there has been some improvements, but of course there will be patients where it's far too difficult for them to travel. And, it wasn't till I think 15 or 20 years ago that Darwin had a radiation centre built. And then before then, patients within the Northern Territory all had to fly to Adelaide to have treatment. So we're still not, able to have each patient within 100 kilometres. So again, having things like telehealth for their initial appointments and accommodation and transport, as well as, ways to cover their financial costs is important for patients if they choose to have radiation treatment. I think for those living further away, when there's an alternative option of surgery, they may often choose to undertake surgery. For other cancer types, whereby, we don't have the same evidence for surgery and radiation having equitable outcomes, then it'll be more challenging for patients where they actually do need radiation therapy as their only treatment option. Then we run into those issues about accommodation, transport, how to make sure that they still have enough family support, social supports. So all of that is very important to ensure that our rural and regional patients are looked after.
Denzel?
Yeah, I had a follow-up question, and this is going to demonstrate my ignorance, but this division between the public and the private sector here seem very stark. And so from Jane's comment, I'm guessing that the problem is just the setup costs associated with, so I'm wondering why there isn't a bigger, this is not a good thing to say when we're worried about equity, but why isn't there a bigger private sector for radiotherapy? Right, so because it then becomes one treatment's associated with the private sector, the other treatment's associated with the public sector. And so there's really no, that's the choice, right? So it's confounding the problems that you've got, that one treatment, that the treatments themselves, are equally as good.
It's a good question. So when I first started training, which was quite some time ago, there really weren't many private radiation centres available. But over the last decade, there really has been a huge increase in the number of private radiation centres. I guess for these private centres to have, a model which is going to be financially beneficial, they need to have a certain number of patients who are going to come through each year. So you need to have an area where, firstly, there are enough diagnoses of cancer, and secondly, there's not necessarily a good public option nearby. So there have been some areas where private machines have gone in recently in New South Wales. Revesby, for example, is one. But I think we're probably going to see that increasing more and more. And there have been, there's at least one case I know of a public centre in Australia that was taken over by the private sector, whereby, I can only imagine that the private companies will approach the public and say, look, we can do everything that you're doing for much cheaper. So I think we're going to see the landscape changing more, but I guess the differences remain still at the moment in terms of private health insurance, that those patients who go ahead with radiation therapy in the private, they can't use their private health insurance. They will end up Medicare will be billed, and then they'll pay their out-of-pocket costs, which is different for patients who receive chemotherapy. They can use their private health insurance to undertake chemotherapy. So it's odd. It's the way that it's set up, but that's the way it is at the moment.
Okay.
I think part of it has to do with, my understanding is that because radiation therapy is an outpatient treatment, that's why it's Medicare rather than private health insurance. Whereas even if the people receiving chemotherapy only are sitting in there for a few hours, I think they're getting billed as potentially similar to an inpatient, so that then they can use private health insurance, is my understanding.
Anyone else? I might jump in with one. I think you touched on this in one of the papers you referred to, but I was wondering if you could reflect a bit more on to what extent patients are just following their doctor's recommendations and they're just being referred to a surgeon, vis-a-vis they actually just want surgery to maybe just get it out. You mentioned that they might feel that's a more final cure. Yeah, if you could just reflect on those two sorts of influences on the decision to treat.
Yeah, and certainly that's another limitation of our study. We can't speak for the men and how they made that decision. So the thing that's unusual with prostate cancer when compared to other cancers is that the person who makes the diagnosis is also the person who provides a treatment. So the urologist will be the first person to see the patient, do the biopsy, and then at the same consultation can talk to them about an operation. And then it's really mainly up to the urologist to then say, oh, actually, there is a colleague of mine who gives another treatment with equal survival. You should go and see them. So in a sense, people have used the word gatekeeper to describe it, the way that, prostate cancer is diagnosed and then managed. And that's different to, for example, breast cancer. The surgeon, or often by the time the patient has been referred to a surgeon, the diagnosis is already made through breast screen, through mammography, and then a biopsy is done through the breast screen service, for example. The surgeon will do an operation, but the radiation treatment is what we call an adjuvant treatment, which is given after surgery to reduce the chance of the cancer coming back. So the treatments are both needed and they work differently. So there's no sort of competition, I guess, between the two treatments. They're not providing the same benefit to the patient. They work slightly differently. For prostate, that's a completely different situation. And I think really it's one of the few cancers where that happens, whereby the surgeon is going to see the patient and then, diagnose it and then also offer a treatment. So look, there may be some patients who prefer to undertake an operation, just want to have it out, that you then get the pathology report and if it's been potentially successful and everything's been removed. However, from the data we've shown is that 1 in 8 men before having an operation are seeing a radiation oncologist, and really that's suggesting that they're not really having a true informed consent for their operation, because the definition of informed consent, you should actually understand all the alternate treatments or the treatments that are also available to you. And I wouldn't be able to consent a patient for an operation. That's not my specialty. And similarly, I think it'd be better for a urologist to refer to a radiation oncologist to fully explain the ins and outs of the treatment. There is data that has shown that men who are seen by both a radiation oncologist and a urologist, that there is an increased chance of them undertaking radiation therapy compared to those who only see a urologist. That's from the US and Canadian data. So while it may still not be, 50-50, if they were both seeing radiation oncology and surgery, it may not end up being 50-50 in Australia, but I think it certainly would, I think it's the chance of it getting closer to that from 2 to 1, I think would be more likely if they could see both specialists and discuss both options.
So does that suggest a role for GPs here? So they're the ones presumably doing the referrals. So is it the norm that a GP would refer to a urologist in the first instance?
Yeah, so the GP will refer to the urologist to make the diagnosis, and then often after that, they see the urologist, they're diagnosed, and then they could be booked in for surgery from there. We have, so the Royal Australian New Zealand College of Radiologists has an advocacy campaign called Targeting Cancer. And that part of that, and a lot of it came out of this issue with regards to prostate cancer, to try and educate the community as well as GPs and other doctors about radiation therapy. And so as part of that, There have been education sessions for GPs organised for them to come and tour the radiation centre and see what it's about, because most GPs have never seen a radiation machine before. And so that's potentially a way that these patients can get referred, but then that often would mean that the patient would need to go back to the GP and say, look, I've been diagnosed with this, a urologist has offered an operation, I would like another opinion. And so they may or may not do that. I think our data shows that they probably haven't done that. They haven't gone back to their GP.
That's really interesting, Anne. Thank you. Could you just explain then how the referral pathway happens for the men who do end up with sort of radiology as the primary treatment?
So usually the urologist who's made the diagnosis will refer to a radiation oncologist. Often that is men who are elderly and may not be fit for surgery, and then they may then get referred on to the radiation oncologist for the opinion about radiation therapy. I hope this is the case. In an ideal situation, a urologist would refer all their patients on for another opinion, because if the evidence is showing that the survival is the same, then ideally they should be referring all of them on to see a radiation oncologist. But the buck's kind of stopping with the urologist. They have to then take the initiative to refer. Also, ideally, all patients should be discussed at a multidisciplinary meeting. So with most main cancer types, we have a multidisciplinary meeting, which is usually an hour a week, where cases are discussed. And then we say, look, they should be seeing X, Y, Z. For urology, I think there's just so many cases that go through that not every case is going to end up being discussed. And it may well be that patients who are brought to that meeting, because there's such a high volume, may be ones where other treatments other than surgery are needed for whatever reason, whether it be they're older or they have some contraindication to an operation. But I think the bread and butter ones, they may not be reaching. Not all of them may be reaching those multidisciplinary meetings.
It sounds like not.
Can I have another question, Serena?
Please, Jane.
Mei-Ling, who owns the robots and who involved in robotic surgery, and what's the sort of level of cost of those?
So this is my radiation oncologist understanding, so don't sort of quote me on all of this, but my understanding is that the surgeon will buy the robot and that it's a number of millions of dollars. I don't know specifically how many millions, but it's in the millions, and that in order to then recoup those costs, there's quite a number of patients who have to be treated to break even.
Yeah, it's a very strong financial incentive to recoup your investment.
Yes, so I've always tried to be quite level when I present this, this data. So I try not to draw those kinds of conclusions, but that's, I think, that, it may be that that's playing a role.
Well, is robotic surgery only available in the private sector, not in the public sector?
So there are a few centres, my understanding is that robots are available. For example, Liverpool Hospital has a publicly available robot, and that's why there is that joint uro-oncology clinic at Liverpool, but most are in private. I don't know the exact numbers. Most are in private, and then, it's great when they're available in public. I'm sure there's pretty long waiting lists, but yeah.
Okay, so that was exactly my question. Is there a differential waiting list story here between the two types of treatment, or is that not an issue here?
So, I mean, I can imagine that there would be a longer wait in the public. I don't know the numbers, but I can imagine that would be longer. And that can often be, putting myself in the shoes of a man diagnosed with prostate cancer. If you see the urologist and they say, look, we've made the diagnosis, we can operate next week, that may be why some patients are very keen to go ahead, but really the data shows in the low risk patients, there isn't that urgency to operate. It tends to be a rather slow growing cancer in the low risk setting, and it doesn't have to be a matter of a week or two to get onto treatment. In the private sector for radiation therapy, my understanding is that patients get on treatment earlier. But again, there isn't data to support that a man with prostate cancer, potentially a particular low risk cancer, needs to get onto radiation therapy within a week compared to 3 or 4 weeks. For cancers such as head and neck and brain tumors, certainly there is urgency to start, but not so much with prostate cancer. So yeah, I don't know what goes on in the urologist consultations. I've only heard anecdotal things, but you know, of course you can understand when men would be, you know, very worried when they're given the diagnosis of cancer, and you know, if that's their trusted doctor, the urologist that they've seen, then they might want to go ahead. But yeah, we'd just like to see these men getting both consultations, and then they can decide after that when they're fully informed.
Right, I think on that note, we might start wrapping up, because the next seminar in this series is actually very complementary to everything that Mei-Ling has been talking about. And let me just bring up this spruik slide here. Next time we'll have Professor Kees van Gool presenting on drivers of higher fees and out-of-pocket costs in radiation oncology. So it really dovetails with what Mei-Ling has presented here. I'm also using 45 and up data as well. But if there are no further questions, then I'd just really like to say thank you to Mei-Ling. It was really a fascinating and interesting presentation. It's bringing up a lot of research questions that I think we would love to have a look at too. So thank you, Mei-Ling, for your time. And everyone, please register and join us for the next seminar.
Thank you.
Thanks, Mei-Ling. Thanks everyone for coming. See you next time.